today is something that I deal with a lot in clinic, which is patients asking me, why didn't my neurologist tell me that? And before I even dive into this, I just want to say no one physician is going to be up to speed on every aspect of Parkinson's disease. I eat, sleep, and drink the nutritional strategies for neuroprotection, and I can't keep up with just that branch of research. So your physician may be excellent at DBS or up to date on all of the, the new pharmaceuticals that are coming out. That doesn't mean they're not a great doc if they're not up to speed with some of the things we're going to talk about today. But the things that I'm going to cover today are the things that are in the published, peer-reviewed medical literature, and they're presented at the Parkinson's disease conferences. They're appearing in the Parkinson's disease journals. And for whatever reason, I feel like they don't make it into the clinical visit as often as they should. So that's a premise for today's visit or talk. My disclosures are here. As Jen said, we're going to make the slides all available, but this is a snapshot of all the things I'm working on and people and places I'm affiliated with. I don't think there's a conflict of interest in anything I'm about to talk about today. The first thing I want to say from the get-go is that we are clueless. You come to your neurologist or your Parkinson's disease specialist to get answers. And I think what we don't say enough is how ignorant we are. Idiopathic, we are clueless. We don't know what this disease is. We don't know what caused it. We don't know how to fix it. We don't know why you got it, but not your siblings. We don't know how to slow it, stop it. We don't know how to improve function over time. There are thousands and thousands more things about this disease that we don't understand than things that we do. So you come into the clinic looking for answers, and I think if we're being really authentic and honest with you, we are as perplexed as you are. I think one thing that I definitely don't think gets enough attention in the clinic visit is how many different things can cause Parkinsonism. Idiopathic Parkinson's disease is a subtype of Parkinsonism, and there are tons of things that can cause Parkinsonism. There are mycotoxins, byproducts of mold fungus that can cause destruction of dopamine neurons in clinical symptoms of Parkinson's. Manganese, heavy metals, B12 deficiency can cause Parkinsonism. Celiac disease has been in the published medical literature shown that it can cause Parkinsonism. You can have autoimmune Parkinsonism. You can have vascular Parkinsonism, genetic forms of Parkinsonism. We know pesticides contribute to Parkinsonism. And so I think so many people do have this why me question. And while we academically study these things, we talk about them at the conferences, I don't think all neurologists do due diligence ruling out or trying to help you identify your particular form of Parkinsonism. I think we are way too quick to put people in the, they probably don't have any of those things, let's call it idiopathic Parkinson's disease box. This is just an example. Most of you do not have B12 deficiency. I just wanted to kind of show you an example or two from the literature of things that have been associated with Parkinson's. Here's a publication called
Hey, Laurie, pause a second. It sounds like your slides are not advancing. Are you advancing them on your end? Yeah, do you want to stop sharing and share again, and let's see if we can make it advance. I'm watching on the other screen, or I'll disappear. I'll keep it.
Are you seeing them now?
I see them there. I just don't see them when they're, well, let's see if we can see them when they're full screen. So try to move that one forward. I see it full screen now.
Oh, I screwed that one up.
That's okay.
That's correct. But you see that advancing?
I see the B12 deficiency.
You don't see this next one?
I don't see it moving.
Okay, I'll just do it in that ugly view so that people...
Okay, that's super mysterious. I'm sorry.
That's okay. Or you know what I bet you I can do is the PDF I just emailed you.
Oh, yeah.
I bet you I can just use that to go through it.
Thanks for your patience, folks. This works great when it works. Sometimes.
Right?
Okay, I can see that. Yeah. All right, we're in business. Keep going.
So I'm just going to go. So here's just an example of a paper called Involuntary Movements Due to Vitamin B12 Deficiency, in which the authors note that both infants and adults deficient in vitamin B12 may present with Parkinsonism, dystonia, all these other symptoms that are very common in Parkinson's disease. And so all I'm saying is that I think physicians should be testing people for B12 deficiency before diagnosing them with idiopathic Parkinson's disease or along the way. And you'll see in a minute, this gets a little more complicated. The other thing I just want to say to people is there is a Parkinson's disease personality and there is a phenomenal Parkinson's disease community. I'm touching on things that I wish everyone were told at the very beginning of diagnosis. We have studied the Parkinson's disease personality for decades, and people with Parkinson's tend to be more dutiful, more loyal, more reliable, more on task, less wild and crazy, and skip less school in high school. And so there is a Parkinson's personality, and it is universally a pleasure to work with, in my opinion, and the Parkinson's community is probably the best part of this disease. There is a true community that gets together at the APDA support groups, the World Parkinson Congress. We do it at summer school. The kind of the way AA has a phenomenal community as part of the medicine. We see that in Parkinson's disease in a way we don't see that in other diseases. Something I wish more people were told repeatedly, and especially early in the diagnosis, is how long you have had this disease. This line right here represents when you're diagnosed. What we now know is for about 10 to 20 years before you get a diagnosis of Parkinson's, you've already had loss of smell, acting out your dreams, erectile dysfunction, constipation. I think that so many people think that their disease starts when they get a diagnosis. And what I want everyone to do is take a step back and realize that diagnosis is just a tool that empowers you to now get engaged and involved and be a more active participant in this process. But this disease is nothing new. You have been living with it for a decade or two or longer. Now you're in a position to do something about it. I think that we don't do enough of talking to people about what the real symptoms of Parkinson's disease are. Everybody knows that Parkinson's disease causes stiffness, rigidity, tremor, slowness. I think we don't talk enough about the non-motor aspects of this disease. According to our research, using the scale that we use most for our research is called the patient-reported outcomes measure in Parkinson's disease. According to our data, 2/3 of the symptoms of Parkinson's for the first 20 years are non-motor symptoms. The motor symptoms, the tremor gets all the attention, but most of what the patients have to deal with, the burden of disease, is predominantly non-motor. And there are a couple of reasons for that. One of the reasons is because we have really excellent therapies that treat the motor symptoms. We have dopaminergic medicines that can make your tremor go away, it can make you move with fluidity. We don't have a lot of treatments for bad sleep and fatigue and constipation and apathy. So it is a combination of good medicines for motor and lacking medicines for non-motor. But what I wish more patients told, what more providers told their patients, is how much of this disease is really a non-motor disease. The depression, the anxiety, things like that. We surveyed a couple thousand people with Parkinson's, and we asked people with Parkinson's, not the physicians, but the patients, to describe the symptoms of this disease. Fatigue, impaired handwriting, and loss of smell were the three most common, followed by impaired memory, muscle pain, daytime sleepiness, before they got into the slowness, the tremor. And so I just really think we need to do a better job drawing attention to how multifaceted this disease is, how diverse it is. There are some of you who only have balance issues and drooling. There are others who only have cognitive issues, constipation, and tremor. So different people will have a different version of this disease, but we're not doing a great job painting a comprehensive picture of what this disease is all about. The other thing I wish everybody were told at the very beginning of this disease is that stress doesn't necessarily make your disease worse, we don't think, but stress will exacerbate all of your symptoms. If you, good stress or bad stress, emotional stress or physical stress, if you are running a marathon, if you, after a hard workout, your tremor will be worse. If you are going on a vacation, you're traveling through the airport, you're planning a wedding, your tremor, your symptoms will be worse. Those are good stresses, but they're still stress. Your body recognizes it as stress, and it's going to make all your symptoms worse. When we are performing at a higher level, we need and make more dopamine. And so when you ask your body to perform at a higher level, whether it's a good situation or a bad situation, your dopamine requirements go up. And so I don't know that everyone needs to take more dopamine when they go through those situations, but I do think that they should kind of have their head on straight and know that when I go through to the airport, I can expect to be moving a little stiffer, slower. My tremor might be a little worse as I'm trying to get through the metal detector, things like that. So I just wish people understood that this is this doesn't mean your disease is getting worse. You're not hurting yourself. You just need to know that the symptoms of the disease will fluctuate with your emotional state. A lot of people ask the question, why me? And of course, for most of us, we will never have an answer to that question. But some epidemiologists have done some really good work looking at all of the studies over the last couple decades that have attempted to ask who gets Parkinson's disease, and are there things in our environment that could be contributing to either protection or increased risk. And this is the most up-to-date, comprehensive, best review that has been published to date. It's by a very well-respected team. And what they conclude is that the people who, if we are looking for the people who are most likely to go on to be diagnosed with Parkinson's disease, they are the people exposed to the most pesticides, consuming the most dairy, those who have a history of melanoma or traumatic brain injury. People who smoke a bunch of tobacco, the more tobacco they smoke, the more protected they are. Caffeine users, blood levels of uric acid are protective. People who exercise, take ibuprofen, and use calcium channel blockers to treat their blood pressure are somehow protected against Parkinson's disease. People who are in this column are less likely to be diagnosed. So you will never know whether or not your milkshakes that you had while you were growing up in Wisconsin, you know, as a teenager contributed or not. You will never know if the fact that you didn't drink coffee is responsible for your disease, but I think that all patients deserve at the beginning of their diagnosis to be oriented like this and to be told that we do know that there are some things that increase or decrease risk. And we don't know that if you start smoking and drinking coffee and taking ibuprofen, that it's going to help your disease over time. In fact, I'm not encouraging anybody to start smoking. But I do think this is relevant for your children. If we know that dairy consumption increases your risk of Parkinson's disease, that's a pretty modifiable thing. Your kids are at slightly increased risk because you have Parkinson's. It might be in their best interest to avoid dairy if they want to themselves avoid a diagnosis of Parkinson's. We don't know yet. I'll get to this in a minute, but we don't yet know if avoiding dairy will decrease your risk. All we know is the more dairy you eat, the more risk there is. Exercise. I was going to ask Jen to do a poll here, but what I just wanted to know is I think that the data on exercise is pretty well established. Of all of the things that we have ever studied, asking the question, is there anything that somebody can do to improve their outcomes over time, decrease their symptoms, increase their quality of life over time? I think the most well-established body of evidence is for exercise. And I would say most doctors are probably in agreement that the more exercise you do, the better off you will be over the long term with Parkinson's disease. And so I do wonder how many of you go in to see your neurologist and are reminded at each visit how important it is to have a regular exercise activity. We published these data this fall. What we did is we looked at the role of social isolation, friendship, social health, and Parkinson's disease progression. And what we saw, we started with exercise as the baseline, but what we could see is the more days per week that a person exercised, the better, the fewer symptoms they had over the next 10, 20 years. And every day mattered, 5 days a week was better than 4, 6 was better than 5, 7 was better than 6. The more days per week that you get at least 30 minutes of exercise, the fewer Parkinson's symptoms people report over time. And this to me is mind-blowing. People who say, I am lonely, being lonely is worse for you than 7 days a week of exercise is good for you. Having a lot of friends is almost as good as 3 days a week of exercise. And so one thing that I want more doctors talking to patients about in clinic is the importance of daily exercise. Don't make it a Monday, Tuesday, Wednesday thing. Make it a daily routine. If you miss a day or two, that's not that big a deal, but you should be in the routine of making exercise a part of every day's activity. And it is not trite to talk about the importance of friendship and social health and community in Parkinson's disease health and well-being. In this paper that we just published, what we did is over the course of 10 years, we asked people with Parkinson's disease, how severe are your symptoms? And we had a true-false section that said, are you lonely? People who said, I am not lonely, over the first 10 years of the disease, their score started around a 500 and it went up to about a, 700 over the course of these 10 years. This is how severe people's symptoms were if they were lonely, 55% stronger. The same graph kind of plotted a different way. These are all of the symptoms of Parkinson's disease: dizzy on standing, urinary issues, memory problems, muscle pain, falls, balance, trouble standing up. The filled in circle in the center is the symptom severity of people who say, I'm not lonely. When we ask lonely people to describe their symptoms, every single symptom is worse. Notably worse, not just a little bit worse. Every single symptom is worse among people who are lonely. And I do think that social health can be prescribed. There's something called social prescribing. I do see a day where neurologists are more involved in making sure that patients are tapped into a community, they're attending a regular support group, that they have a Parkinson's disease buddy that they work with. We need people tapped into a community if we want people to thrive with this disease. I have a couple things to say about meds. Those of you who know me know I am a big supporter of using dopaminergic medications for the management of Parkinson's disease. I am very pro use of integrative medicine, pharmaceuticals, and lifestyle modification. But there are a couple things I want to make sure that people know before they dive into medications. Philosophically, before we even dive into that. When I approach medicine, as Jen said, I'm really committed to the patient-centered care of a patient with Parkinson's disease. For hundreds of years, we have defined and described this disease based on what the physician can see. And I am a huge advocate for shifting this entire disease to be based on what the patient experiences. And so that goes to the clinic visit too. When patients come into the clinic, before you go in to see your physician, I want you to remind yourself, they are working for me. I am hiring them. I'm employing them to give me an opinion. I'm going to them to better understand my treatment options, and my physician's job is to walk me through the different options and the pros and the cons of each. So I think that there's a time and a place to use all of these medications, but what I don't think that we're doing is a really adequate job of counseling people on the potential risks and complications associated with different meds. Levodopa is perhaps the most commonly used pharmaceutical for Parkinson's disease. Many of you watching this video know this already, but a lot of people are not told at the start of their journey that levodopa is just an amino acid, and protein in your diet is just a string of amino acids. So if you swallow your levodopa pill, if you have eaten any dietary protein anytime in the recent past and it's still hanging out in your intestinal tract, the levodopa is not going to work as well. Levodopa and dietary protein compete for the same amino acids in your gut. A lot of the times we will start people with, say something like, hey, make sure to take your medicine, 30 minutes before or an hour after a meal. And that's okay to kind of get started, but that's usually not enough time. And how long you have to wait after a meal depends on how much you ate, whether or not you're constipated, how much stomach acid you make, whether it was a plant-based protein or an animal-based protein. They travel through your gut at different rates. And so that topic of protein and levodopa interacting really probably deserves an entire visit by itself to make sure people are adequately counseled on how to not just take their medicines, but how to optimize their meds working. One of the clues that you might be somebody who has a problem with levodopa and protein interacting is if you say, the morning med is the one that works the best. After that, it's a little more hit and miss as the day goes on. My meds don't work as well, but my morning dose works well. If you're one of these people who says my morning dose works well, it could be that you are introducing more protein than you realize throughout the day. So it is easy enough to try and eat dietary protein in between taking your meds. So that's one strategy. But for those who have trouble with that, or that doesn't quite do it, the next thing that we will ask people to do is a protein redistribution diet, where you actually save your dietary protein for your evening meal. You can have a low protein breakfast, a low protein lunch, save your protein for the evening meal. You will be more stiff, more rigid at night in the evening, but most people are winding down, reading a book, watching TV. They don't need to be so active. But what this does is it clears the way for the meds to work better all day. You can run your errands, you can go exercise, things like that. Levodopa interferes with B vitamins. There's actually some research suggesting that people who use levodopa, not only do they have folate deficiency, but also it interferes with B12. This one's a little more questionable. There are a lot of reasons why somebody's homocysteine level can go up, but just the use of levodopa alone will raise homocysteine levels. The more levodopa somebody is on, and the longer they are on it, the higher their homocysteine levels. The reason that is a problem is because the higher your homocysteine level, the faster your Parkinson's progresses and the higher your risk of dementia. This does not mean that you should not take levodopa. It means that for anybody who is taking levodopa, once a year, your prescribing physician should measure your homocysteine levels and make sure that they're not starting to creep up. If your homocysteine levels start to go up above 10 or 11, 11 is where we start to see the risk. If they start to creep up above 10 or 11, we just give you a supplement that has these B vitamins in it, and your homocysteine comes down very quickly after. You can have your cake and eat it too. This doesn't make levodopa bad. It just means that people on levodopa have some unique risks that they have to be on the lookout for. And there are dozens of studies that show that levodopa raises homocysteine levels, and homocysteine levels increase your risk of progression, worse outcomes. So this is not news. It's just something that isn't making it into the clinic. Here are a couple of references for people who want to go read a little bit more about it. The other thing I think that we don't talk to you honestly and directly enough about are dopamine agonists. There's kind of this outdated idea that younger patients should get started on the dopamine agonists first. Kind of like levodopa sparing, kind of save the best for last sort of idea. That doesn't hold up. There is no evidence to suggest that people who delay using levodopa are somehow protected. That doesn't pan out. That was an idea that was floated around for a while. It seems not to be the case, but there are some people who still have this idea that a young patient should maybe use the dopamine agonist before trying the levodopa. There are some pros to these drugs. I think there is a time and a place to use these meds. They are smoother. They have some long-acting versions of them. You can take one and it'll last all day or a couple. So it tends to be smoother, and it tends to be they tend to be really good at treating restless leg syndrome. So there are some pros, but what I don't think we are doing a good job talking to you about is that There's new research that says as many as half of people with taking these medications will eventually develop some form of impulse control disorder. It could be shopping, it can be crafting, it can be internet porn, it can be gambling, it can be driving fast, buying things. It doesn't have to be expensive things. You know, I have a patient who I believe has like 15 turntables from Goodwill stores. There are a lot of ways that impulse control disorders can manifest, but the consequences from an impulse control disorder can be devastating, financially devastating, devastating to a family when affairs and things like that start coming into play. And it's not the patient, it's the medication making the patient do things they wouldn't normally do. Just because you're using these meds doesn't mean you're going to develop an impulse control disorder, but it does mean that if you are going to decide to use one of these medications, you and your family members need to be on the lookout for these disorders and have a plan for, you know, raising a flag when you start to notice something isn't right. These medications also cause daytime sleepiness. I've had several patients nod off while driving. Is definitely the most dangerous consequence of the daytime sleepiness. And the other thing that I think we don't talk to you about is that eventually you're going to come off of these medications, either when you need something stronger like levodopa or you develop an impulse control disorder. And about 20% of people who come off of a dopamine agonist will develop something called DAWS, a dopamine agonist withdrawal syndrome. And that can last weeks or even a couple months, but it's like a drug withdrawal syndrome. I mean, you're in pain, you're sweaty, heart palpitations, you can't get comfortable, panic attacks. It passes, you can get through it just like coming off of any other drug. But I do think that before people start down this road, their physicians who are prescribing these drugs need to have a real honest heart-to-heart conversation with patients about all of these things. And it doesn't mean that you shouldn't ever use this drug. It means you should be aware of the risks if you decide to use this drug and have a plan for addressing them if they arise. Laboratory testing is something I do a lot of in my clinic. I just like data. It is true that we don't have one biomarker that reflects Parkinson's. You know, if you have prostate cancer, you can measure your PSA. And if PSA goes up, it means the cancer is getting bigger. If the PSA is going down, it means your cancer is going away. I mean, there are just things. Blood pressure has, you know, as for a lot of other diseases, we have biomarkers. In Parkinson's disease, we don't have that one magic number that if we see it going up or going down, we know we're on the right track. So without that, it makes things hard, but it doesn't mean that we don't have any useful data that can come from blood and urine and stool and hair and things like that. And for whatever reason, I don't know why, neurologists don't do a lot of labs. It's just not routine practice. And I just don't know how you make good decisions about how to care for a person without data. So I chose a couple that I just wanted to touch on. Vitamin D, I'm coming to you from Seattle. It's the middle of winter. I think I've seen the sun 5 times in the last 2 months. People across, this is a meta-analysis of a whole bunch of studies that have been done on Parkinson's disease, showing that people with Parkinson's consistently seem to have lower vitamin D levels. In Parkinson's disease, vitamin D has been linked to constipation, more inflammation, muscle weakness, poor balance, depression, and risk of dementia. In clinic, I try to target everybody at this level of about 60 to 80. And remember, the amount of vitamin D that you need depends on how much time your skin is exposed to the ultraviolet rays of the sun. So your distance from the equator plays a role. How much skin you cover plays a role, whether you wear short sleeves or long sleeves outside. My bald patients seem to have better vitamin D levels than the people who have hair. People who cover themselves more are going to have lower levels, and obese people tend to have lower levels. So we don't know who needs vitamin D unless you test people's blood levels. Especially with COVID happening, there's some reason to believe that the lower your vitamin D levels, the greater the COVID risk. So this seems to be an especially important time to make sure that you don't have vitamin D deficiency. I've already talked about the B12, the link between B12 and Parkinsonism. As part of my standard workup, there are 3 tests that need to be done before you can say you probably don't have B12 deficiency. This is the name of the 3 tests: methylmalonic acid, homocysteine, and serum B12. A B12 alone is not enough to say you do or do not have deficiency. You actually need all 3 of these to be measured to be able to rule out a B12 deficiency. Another one that I think we don't use nearly enough is something called high sensitivity CRP. This is a measure of inflammation in the bloodstream. What we know is we looked at thousands, the royal we, I think it was like something like, it was thousands of people in this study. And they looked at people's baseline levels of inflammation, and 0.8 was the magic number. These lines reflect what was the person, all of these people have Parkinson's disease. What is the likelihood that you are still alive 10 years or so after diagnosis? And you can see that people who had a CRP level greater than 0.8, there was only about a 50% chance, not even, that they were alive 10 years later, as opposed to people who had low inflammation levels, a much higher likelihood of being alive 10 years from now. So it's probably an $8 test. You can measure high sensitivity CRP. There are a bunch of studies on high sensitivity CRP and Parkinson's disease, with the studies concluding things like, elevated high sensitivity CRP may have clinical value as a risk factor for Parkinson's disease. These studies, you can read the details of them later, but they basically say the high homocysteine is found in Parkinson's disease. The higher your inflammation in Parkinson's disease, the worse your outcomes over time. And that there may be some real clinical usefulness for us to start measuring in more people for inflammation, high sensitivity CRP. The $1 million question is, can it be lowered? And I'm here to tell you very, very, very easily. I see people on the first visit. I measure everybody's CRP. Most people are high when we first meet. I send them home with dietary recommendations, correcting a vitamin D deficiency, a couple of things like that. And about 75% of people, when I see them 2-3 months later, are no longer elevated. I would say this is one of the easiest biomarkers to influence in my experience with Parkinson's. There is research that says the more yellow, red, orange, fresh fruits and vegetables you eat, the lower your inflammation. Vitamin C, specifically vitamin C coming from citrus, green leafy vegetables and berries. People who consume the consumption of soy products and non-fried fish are all associated with lower CRP levels. And you'll see in a minute, this looks a lot like a quote unquote Parkinson's disease diet, and the diet that I recommend for people when I'm trying to get their hsCRP lower. Which brings us to diet. There is no double-blind placebo-controlled trial that says if you change your diet, you will change your outcomes. And that is not coming anytime soon. 10, 20, 30 years from now, maybe we will get some funding to do that kind of a study. But what we do know is that several studies now have said that diet influences whether or not you will be diagnosed with Parkinson's disease. As you might expect, fresh fruits and vegetables and nuts and seeds, plant-based diet, beans, mushrooms are associated with less of a risk of Parkinson's diagnosis, whereas meat, dairy, fried foods, and sweets are associated with increased risk of diagnosis. But more exciting, in these last couple of years, there have been a couple studies that suggest that even among people who have prodromal Parkinson's disease, they have these early symptoms, the loss of smell, the REM sleep behavior disorder, they're acting out. Even in these people who already probably have Parkinson's disease underway, the greater their adherence to a Mediterranean diet or a MIND diet, the longer it was before they actually got their diagnosis of Parkinson's disease. So we're starting to get our first hint that maybe diet can actually modify the progression of this disease. So this brings us to a lot of the work I have been doing. I have published this study where we are now up to 2,500 people with Parkinson's disease. And what we did is we looked at, this line is the average rate of Parkinson's progression over time. Most people start with a score of about 500 and get worse at 40 points per year. when you cross this line of 100, which usually happens right around year 10, around 1,000, your quality of life goes from good to fair. So what we are trying to do is keep you in this green zone for as long as humanly possible. I want everybody less than 1,000 on their 100th birthday. And so what we have been doing is trying to figure out, who are these success stories? Who are these people who 10, 20, 30 years after their diagnosis, their quality of life is still excellent or good, versus these people who seem to be progressing unusually quickly. They have a surprisingly fast rate of progression. What we have learned is that dietary behaviors play a major role. The inability to afford food and afford healthy food is perhaps the biggest risk factor for rapid progression. And people who cook most of their own meals at home or prepare meals for others, people who avoid artificial sweeteners, colors, and flavors do better. People who I try to eat organically grown foods when possible, and buying from local co-ops, CSAs, farmers markets, things like that. Those are the people who tend to do better over time. In terms of which foods to eat, I'm going to flip this in the next slide just so that you can see it a little bit better. But we asked the exact same question. What are the actual foods that people are eating that are associated with better or worse outcomes over time? This slide, you can print this out at this website, Living Healthy with Parkinson's Disease. I encourage you all to go there, print it out, and hang this on your refrigerator so that you're reminded every time you go in your kitchen. And the more of you who participate in the study, the more accurate, the better, the stronger the data becomes. So here's the link for those of you who would like to join this study and kind of help us get a better understanding of some of these things. But here's what the data say. Pretty clearly and very consistently, the more fresh vegetables, fresh fruit, nuts and seeds, non-fried fish, wine, olive oil, coconut oil, and fresh herbs a person eats, the better they do over time. The new data, the stuff we're going to publish in a couple months, spices are also on the list, green and black tea, and soy products and eggs all look like they are on the good list. On the bad list, canned fruits and canned vegetables, soda, especially diet soda, fried foods, all dairy, ice cream, yogurt, cheese, milk, and butter will be on the next list that we publish. Beef, pork, and chicken are on this list. For some reason, turkey is still not on the list. We ask about turkey, but turkey seems to be neutral. Pasta and bread will be on the new list. Drinking out of plastic bottles. And frozen vegetables, for some reason, are associated with faster Parkinson's disease progression. So I cannot guarantee any of you that if you stop eating all of these foods and start eating tons of these foods, the rate of your disease will change. What we can tell you with greater than 95% confidence is the people who are doing the worst with the fastest rates of progression are eating these foods, and the people who are doing the best, who seem to not be progressing or progressing very slowly, are living off, eating the most of these green foods. So it may be that your physician has incredibly high standards for research, that when there is a double-blind, placebo-controlled level 1 evidence study, that they will begin to tell you that you should change your diet. It may be that they're just not up to date on some of this research. I don't know why more physicians, with the data that has been consistently coming out, and even though we don't have a ton of data, the data that we have is pretty consistent, and it matches a lot of what we're seeing in Alzheimer's disease. I can't really figure out why your doctor wouldn't say, listen, we might be wrong, you might be eating a bunch of broccoli for no good reason, but the people doing best seem to be eating a lot of vegetables. If I were you, I would start eating as many more vegetables. I'm not sure why we're not having more of those conversations with our patients. So in summary, I just want to remind you all that your healthcare team, all of your physicians, your physical therapists, your social workers, your occupational therapists, your physical therapists, we're all working for you. You are the boss. We are your employee. I want you to feel confident when you walk into any of your appointments. Have your list. You are there to get your questions answered. Your job is not to do what I recommend or what your physician recommends. Your job is to make sure that you understand the pros and cons of all of the options that are currently available to you. Just because your doctor doesn't know A or B doesn't make them a bad doctor. They may be the world expert on C and D, right? That's why you need a team. You don't throw the baby out with the bathwater. You need a team of people with different types of expertise. And, you know, it's your job. It's your job to build your team with experts from a whole bunch of different fields. All right, that's the end of my chat, and I'm happy to take some questions.
Thank you very much, Laurie. I always learn a little nugget every time I hear you speak. We are going to take questions from you who are there. If you could use the Q&A box to type your question, that would be great. We have a couple of questions already in the Q&A. We have a couple in the chat. So I will just launch in. The two in the Q&A actually are kind of a little bit more about the B12 vitamin B stuff. So the first question was, what supplement do you recommend for B12 folic acid? And a corollary question is, should vitamin B supplements be part of sort of the Parkinson's person's supplement routine?
Only if you are deficient in B vitamins. I mean, if I gave you everything that I thought might be helpful, you would be taking 1,000 supplements a day. You would be spending a ridiculous amount of money. It's just not, it doesn't make sense. I want people to use only what they need. There are, in our research, we haven't gone public with it, but there are a short list of supplements that just generally speaking seem to be associated with better outcomes over time. Glutathione, coenzyme Q10, lithium, Mucuna seems to be doing well. Some things that we're kind of surprised how well people who are on those supplements seem to be doing. So there might be a place where we are evolving towards a Parkinson's specific general supplement. Anyone with a diagnosis of Parkinson's should probably be taking glutathione. For those of you who don't know, my PhD is in glutathione deficiency in Parkinson's disease, and my funded research from Michael J. Fox Foundation and the NIH has to do with using intranasal glutathione spray to raise brain levels of glutathione. So we know that glutathione is low in Parkinson's. It might be something like that for some of these supplements, but for B12, the only people who should be taking it are the people who have reason to believe that they are deficient.
Is there a specific, how do you find the right supplement? There's so many different supplements out there. So I think that first question was like, what supplement would you recommend? Is there a place to go to find the best supplement? Because I know they're not all created equal.
Yeah. So I have a 90-minute class answering that question in another forum. But the one that I go to most and start with is a very cheap pharmaceutical grade supplement called homocysteine factors. I believe the company is Integrative Therapeutics. It's called, I don't remember who the company is, but it's called homocysteine factors. It's maybe $17 a month. And I only give it to people who have high homocysteine. And I measure their homocysteine levels a month or two later, and we can clearly see it working or not. If it's not working, then some of those people actually can't absorb B12 orally and have to use B12 shots or a sublingual form of B12, which is where your physician comes in. I mean, you know, every physician, whether you went to naturopathic medical school or conventional medical school, we all learn that the number one cause of B12 deficiency is gastric atrophy, and your stomach is unable to absorb B12. So a lot of the B12 supplements that people swallow are completely useless. If B12 is your problem, there is no pill you're going to swallow that's going to work. You either need to show up for injections a few times a month, or find a fancy form of B12 that will dissolve onto your tongue. But that's what your physician will kind of help you figure out what is the cheapest, most convenient, most effective B vitamin supplement for you that lowers your homocysteine level. But the product called homocysteine factors is where I start.
Okay, great. Red wine versus white wine.
I keep joking that I'm going to set up a fundraising bucket for that study. And if everybody who wants an answer to that question just pitches in $10, we will fund the entire study. because that is the number one question I get. I don't know. We have added the question. So think of this first round of questions that we asked as kind of a wide net. We went into the lake just to see where the fish were biting. Now that we have a sense of where the fish are biting, we're not just asking about bread. We're asking, well, what about gluten-free bread? What about gluten-free pasta? We're not just asking about wine. We're like, well, red or white? What about champagne? You know, and so we're starting to, this is round one. And again, the more people who participate in the study, it's like a microscope that allows you to fine tune, the more detailed answers we can give you. So right now, with 2,500 people in the study, I can tell you that wine consumption is associated with better outcomes over time. When another 1,000 of you join the study, we'll be able to tell you red or white. So
Sure.
Please come join.
And speaking of wine, we have a lot of wine that we're auctioning off at the Magic Hope Gala next Friday. So if you want to increase your wine consumption responsibly, come bid on some wine. It'll be there. So anyway, moving on. Is loneliness a function of mental outlook or physical reality?
Yes. You know, it is absolutely mind-blowing to me how exercise can improve attitude. I mean, how attitude can make you want to call a friend or go for a walk. I mean, it is such a complicated, interconnected, you know, I mean, there have been 2 head-to-head studies with the Mediterranean diet and pharmaceutical antidepressants, and the diet is equally effective or more. I mean, it is so, when people come in and they say my depression is chemical, I'm like, okay, what does that mean? It's still going to get better when you go eat more plants and exercise. Just because it's chemical doesn't mean it's not born from our habits and our patterns and our food and our hormones and our things like that. So it's complicated, but the way I look at it is there are things that we can control and there are things that we can't. And it is a lot easier for me to modify my social connections, call more friends, get a little more activity, eat a little bit different. I can't modify apathy. Like I can't just wake up and say, I want to be less apathetic. But all these other things are associated with less apathy. So until we know what causes what, just figure out what you have control over and get to work on those things. And it's pretty amazing how pieces start falling into place.
Mm-hmm. So speaking of exercise, you talked about the 30 minutes of exercises. This says, is that cumulative or is that 30 minutes continuous exercise?
We just asked the question, and again, our exercise questions have gotten much better with the new edition of this study. But when we started this, we were just asking on how many of the last 7 days have you done at least 30 minutes of exercise? And so, and it is amazing how yoga and Tai Chi are as effective as some really intense workouts. I mean, it doesn't need to be heart rate sweaty for you to get the benefits. I mean, just being mindful helps. Just being in an uncomfortable position, doing something outside your comfort zone, that all seems to be somewhat therapeutic.
And last month, and it's up on our YouTube channel, Dr. Nate Coomer, who's a great physical therapist, did a talk on apathy and exercise. So if you want more information, you can go watch that, or you can go to the APDA website and connect with the Boston Rehab Center, which is our national exercise place. So, you know, they have a lot of recommendations and connections of that. So what does lithium do to help people with Parkinson's disease?
One of my favorite topics. So my undergraduate work is in, my undergraduate degree is in nutritional sciences, and my PhD is in nutritional sciences. And one of the things, like back when I was a little kid, 20 years old, 21 years old, was so amazing to me about nutritional requirements were the ones that were just, you know, like one of my favorite quotes is, there are 3 truths in science. First, they say it isn't true. Then they say it's true, but not important. And finally, they say it's true and important, but not new. And that has happened with nutrition where, you know, nobody questions humans need vitamin C, right? Scurvy has been established. We know what it is. We know how to cure it. We understand it. We are all sold on things like vitamin C deficiency. there are a whole bunch of minerals that we know the human body needs, but we don't fully understand what they do. And they're not listed on the daily list of required nutrients: boron, manganese, lithium. And so there are these nutrients that we know are a function necessary, but our doctors don't measure them, and we're not looking for them. We just assume people are probably getting enough in their fruits and vegetables, but now we're not eating fruits and vegetables, and the soils are all depleted, and so people's mineral levels aren't the same. So I years ago got very, very interested when I learned that lithium was a required nutrient for the human body. Every cell needs and uses lithium, and neurons need more lithium than any other body part. And when lithium levels get low, a couple things happen. Neurons become very susceptible to hyperexcitability. There are some studies that show the lower the lithium in the water supply, the higher the rates of addiction, violent crime, psychosis, anxiety and depression, I think. Suicide, the lower the lithium in the groundwater, the more suicide in any community. And this has been studied throughout the world. And then about 10 years ago, they started studying the role of lithium deficiency in neurodegenerative disease. In Finland, they went county by county through the water supply, showing the lower the lithium in the water supply, the higher the rates of dementia in that village. And for my master's work in epidemiology, my thesis was on lithium deficiency and Parkinson's disease. And what we found is that people who were low in lithium, Parkinson's patients were 74 times more likely to be lithium deficient than their age-matched counterparts. And so I truly think that lithium deficiency makes the brain susceptible to psychological and neurodegenerative diseases. And if we were a wiser society, we would be, there are scientists who for 30 years now have been calling for the lithiation of the water supply in regions that are lithium deficient. I mean, just like the northern half of the United States doesn't have iodine, so we iodize your salt. Same thing, there are a whole bunch of the United States and around the world places where there isn't enough lithium in the groundwater, and those places need to be fortified. But right now there are no fortification efforts being made. And I truly believe that those places with lower lithium levels are suffering unnecessarily adverse neurological consequences.
Sounds like you could do an entire talk on that. 90 minutes, 2 hours, all of it.
Lithium, right?
Exactly. So we were successful going live on Facebook. And so we have a question from our Facebook audience. Do you see a difference in Parkinson's disease severity / progression with prenatal vitamins?
I don't recommend prenatal vitamins. I don't monitor outcomes. I would be guessing. I don't know. And in fact, it might, the only supplement that is associated very clearly with worse outcomes in Parkinson's disease is iron. People with Parkinson's should absolutely not be on an iron supplement, and a prenatal vitamin is probably going to have extra iron in it. So I would actually probably say you shouldn't take a prenatal vitamin with Parkinson's.
Okay. So you talked about wine. This is a whole nother talk, but I'm going to ask it anyway. What about THC?
I would say cannabis is the single best tool I have found in 20 years to improve the sleep of people with Parkinson's disease. I usually start with melatonin. I start with sleep hygiene. There's cognitive behavioral therapy for insomnia. There are a lot of things that you can do to set the stage for a good night's sleep. I've been making everybody get Oura rings lately and tracking their sleep patterns and things like that. But truly, nothing is more effective to get a patient with Parkinson's a fabulous night's sleep than cannabis. So when people ask me about cannabis, my follow-up question is for what? It's not going to be the answer to your tremor. It may or may not help your dyskinesia, but most of the time you have to be high to get those benefits, and people don't necessarily want to walk around high all the time. But at night, there is a way to dose it in such a way that you don't get high, you just get a good night's sleep. And it's pretty amazing. People will say to me, where did the urine go? I used to get up 5 times a night and pee large amounts of fluid. Like, I get that cannabis helps you sleep, but where did all that urine go? And there's just so much we don't understand. I don't know where it went. I don't know what's getting re-regulated. But I would say of course, some people like the mood enhancing, euphoria. The top three reasons that people use cannabis medically when we ask patients are pain, anxiety, and depression. And so I do think that if I'm going to use cannabis in clinic, it's almost always to help sleep. One of the side effects is it can improve people's mood disorders. The anxiety and depression actually might benefit a little bit.
Okay, thank you. Question about the study. How often in the study did people report on their diet? And are people keeping a daily record, or how does that work?
Yeah, food is really hard to study. And so there are a couple things that save us. We are creatures of habit. Most Americans eat the same 10 foods over and over and over in different patterns and ratios. And we from one person to the next within one person, there isn't a crazy amount of diversity for most people. So the way we do it is we ask twice a year, every 6 months for years, we ask you, how often do you eat in the last 6 months? How often would you say you eat vegetables? How often do you drink wine? And we ask it in a form that is called a food frequency questionnaire. And then what we also do is about a week or so later, you get a follow-up survey, and we say, all right, stop what you're doing. Tell the penguin everything that you've put in your mouth in the last 24 hours. And that's where you get real specific about, I had a Caesar salad. And then, you have 8 different sizes to choose from, a small one or a large one, heavily dressed or lightly dressed. And so that's where we get real details about not just how many servings of broccoli did you have, but we can start to estimate how much vitamin C or folate is this person getting in their diet based on that 24-hour dietary recall. So we're doing it from a couple different angles.
Okay. And you are still welcoming people into that study, correct? Yes.
Please.
So I will send a link out to that study in your post-event email if you want to partake in this big study that they're doing. And speaking of vitamin C, does citrus fruit and juice impact levodopa absorption?
Yeah, so there are a couple studies, 2 studies, I think they're 20 years old now. But what happens is about 60% of people with Parkinson's don't make enough stomach acid. With age, our stomach starts to not work so well. Kind of stereotypically think of the little old lady who eats a couple bites and gets full very easily. As we age, our stomach becomes less and less good at making stomach acid. And you need stomach acid to digest your food and to activate your levodopa. And so for that reason, they wanted to see whether or not supplementing acid, when people took their levodopa, if they take it with a little bit of acid, could that make for better absorption of levodopa? And one of the studies used powdered vitamin C. I think it was maybe 500 milligrams. It was like a half of one of those powdered vitamin C packets. And the other study used 1 full lemon's worth of lemon juice. It was 30 mils of lemon juice. And both of them, for people who had low stomach acid, both of them were very good at enhancing the absorption and availability of levodopa. So what I will often have people do is don't become obsessive about it. You can take your meds even if you don't have any vitamin C laying around or a pile of lemons. But if it's all the same, Trader Joe's for $3, you can get a bag of organic lemons. If you get up in the morning and squeeze a lemon into a glass of water, and that's how you take your first dose of levodopa, why not? As long as you're taking the pill, you may get an extra 20-25% out of that pill just by taking it with a glass of lemon water. And so I do think it's a good trick. So for people who find that sometimes their meds work better than others, or they don't get a very robust response sometimes when they take their meds, they might want to try that trick of taking their levodopa with a little bit of acid. And the 2 that have been shown to work the best are powdered vitamin C or 1 full lemon's worth of lemon juice.
Okay, great. Thank you. I'm going to ask one more question because I know you have a hard stop. Some confusion about the protein thing. So I just want to clarify this because this is always a question that people have. I think it said avoid protein 1 hour before and 2 hours after. And other folks have heard it flipped. So can you just clarify what the best practice is there?
The best practice is to don't eat protein all day long and save your protein for the evening meal. Have a smoothie for breakfast, a bowl of oatmeal with some fruit. Try and minimize protein for breakfast and lunch, and then have your piece of fish and your nuts and things later on in the day. If you are going to start to insert protein, it's really a game of playing what can I get away with? There are people who can sit down and have a cheeseburger, take their pills, and be fine. You know, those people have really hardy, impressive digestive enzymes. That's not the case for most people. I have other patients who tell me that an avocado has enough protein to interfere with their meds. I have a patient who tells me if she has red meat for dinner, her meds don't work the next day. And so you really have to figure out how sensitive are you. But the point of that slide was, you know, when we're sometimes just kind of trying to get you out the door, we'll say something like, be sure to take your meds half hour before or 1 hour after a meal. And that's just kind of like Parkinson's 101. But it is so much more complicated than that. I mean, the protein in quinoa or hummus might, you know, within 30, 60 minutes have moved through you. Because those are all smooth, they're pre-digested, they're liquid, it's plant-based. Plant-based foods move through you a lot faster. But if you have something like a chunk of chicken, is 4 to 6 hours. Red meat is 6 to 8. It takes a lot longer to move animal products through you than plant products. And even if you think in terms of texture, say you're going to have a meat chicken in soup or stew is going to be a lot more quickly digested than a chunk of flesh, or a baked chicken breast or something like that is going to be harder to digest than than the chicken that is found in soup. And so it's not just, there is no guideline about the 1 hour before or 2 hours after. We're all kind of guessing and making something up just as a starting place. Every one of you needs to kind of take a couple days where you try and go low protein, kind of get a sense of, oh, that's how well my meds are supposed to work. And then start sneaking in a little peanut butter with your apple and seeing, okay, that didn't interfere with anything. I can get away with an apple and peanut butter between dose 1 and 2. And then you start playing, what can I get away with? But there are some people who are really, really, really sensitive.
Okay, great. Thank you. So last thing that I want to ask you about is you started a couple years this crazy PD summer school idea and have now sort of transitioned it to this online summer school. So do you want to, in case any of you like what Laurie is saying and want to learn more, you want to tell us a little bit about that?
Yeah, there are two things. Thanks. So my idea was that there is not enough time in clinic to tell patients everything that they should know to live a long, healthy life with this disease. It's not that we disagree on the material, there just isn't enough time in clinic to go over it all. And so I had this idea that I would make a class called Online Parkinson's School. And so I started this idea about 4 or 5 years ago, and then Bastyr University said, well, what a good idea. Why don't we have the summer school? And so we have a 1-week camp every August where people fly in from all over the world, and we have a camp where we eat together, sleep together, exercise together, things like that. Bastyr just got their act together way before I did. And so we've been doing the summer school version of it for 3-4 years now by the time I got the class situated. But now the class is kind of a cheaper, more accessible, easier version. And so I don't know if we can get to the website, but what I've done is I'll write the code in the.
I can send it out in the post-event email, so just send that to me. So,
yeah, that'll be great. So there is a 24-course series called Online Parkinson's School, and it's basically everything I'm telling patients in clinic all day long, everything I know, I tried to dump on this course. And then what we're doing is on the 14th and 28th of every month this year, we're having a live, let's talk about last year's class. And it's been fabulous. We go through a Q&A, we form little breakout groups. I kind of update people on what I've learned in the last year. And that has actually been more fun than anything. And I actually, before I logged on today, I just made a coupon for people who are watching this talk. Anyone who signs up in the next, before the end of the month, I made it half off with the coupon APDA. So I will give you that coupon in case anyone wants to jump on that.
Okay, All right, and I will outline all this. Just watch for an email from me early next week. I will post the video to this talk. I will post the slides that Laurie has provided me, and that'll all be up on our YouTube channel that I will link to in the post-event email. I will link to the study and the information about that, so you all can have that information that you need it. So thank you so very much for sharing this. I know we could have done a 4-hour, 6-hour thing and you could have just talked, but you did a good job on timing here. That's great. So I hope that all of you online will consider joining us, A, for our Passport to Research series, B, for our Magic Hope Gala next Friday. Just come check it out. It's going to be great. We got a walk in May. We've got a lot more coming in the Take Control series. April will be about cognition and PD, and then more to come. So stay tuned, and we hope to see you next time. And if we didn't get to your question, I'm very sorry we didn't. If it's really a burning question, email it to me and we'll see if we can answer it. But you know, we're starting to run out of time, and we've got Dr. Mischley has some places to go right now. So thank you all very much. Any parting words?
I just want to say that I have now been treating several thousand, 3,000-4,000 patients with Parkinson's over the last 20 years, and I remain sincerely, honestly, more convinced than ever that this disease is absolutely modifiable with lifestyle. And it is absolutely possible for somebody under the age of 50 to be diagnosed and still live to be 100 in good shape.
It's very hopeful. It's great. Thank you very much. Have a wonderful weekend, and we'll see you again, and we will see the rest of you online again. Please feel free to reach out to us either via phone 206-695-2905 or on our email apdanw@apdaparkinson.org. Such a mouthful. And we will see you next time. Thank you very much.
Bye.
Bye.
The invite.